Good morning. CDC is proud to again be part of World Thrombosis Day. This global effort highlights the often overlooked, underdiagnosed, and misunderstood disease of thrombosis. As you know, thrombosis is a leading cause of death and disability worldwide. This year's focus is healthcare-associated thrombosis and the need for routine assessment of all hospital patients. Many people may not realize that thrombosis is an underlying condition that can lead to the top 3 causes of cardiovascular death: heart attack, stroke, and venous thromboembolism, or VTE. VTE is a serious and apparently growing public health problem that refers to blood clots occurring as deep vein thrombosis or pulmonary emboli, or both. More than half of VTE events are associated with a recent hospitalization or surgery. VTE is a leading cause of preventable death in the hospital. It's estimated that there could be up to 900,000 VTE events each year in this country, resulting in as many as 100,000 premature deaths and healthcare costs as high as $10 billion a year. Anyone at any age can develop VTE, but some people are at higher risk. Patients who are currently or recently hospitalized, recovering from surgery, receiving cancer treatment, or on bed rest have an increased risk. Among patients with cancer, VTE is a leading cause of death. Fortunately, prevention steps such as anticoagulant medicine and compression devices can reduce the chances of developing a blood clot. Complications and death from VTE can be avoided with early and accurate diagnosis and effective management. To address this, in 2015, CDC launched the Healthcare-Associated VTE Prevention Challenge to recognize hospitals, managed care organizations, and hospital networks that have implemented effective, sustainable VTE prevention programs. 8 champions were identified, ranging from single hospitals to large multi-hospital networks. Strategies that these champions used illustrate the importance of routinely assessing every patient's risk for VTE, using electronic health records and clinical decision tools, prevention strategies for those at risk, and improving education and awareness for both patients and healthcare providers. These champions show that evidence-based prevention strategies can be implemented across a wide range of hospitals and health systems. We can learn from their efforts and hope that others can learn and be encouraged by their progress. CDC is working to better understand the causes, burden, prevention, and outcomes of VTE in order to reduce the burden. We encourage every healthcare provider to routinely assess the VTE risk of every hospital patient and take action by implementing prevention measures. We also have to recognize that as much progress as we've made, as many useful prevention tools as we have, these aren't enough. Even with good adherence to assessment and prevention, too many patients will develop VTE. For some, the hospital bed is the culprit. Getting patients moving safely as soon as humanly possible is one way we may be able to further decrease VTE. For other patients, we may need better ways to reduce clotting without increasing the risk of bleeding. And we definitely need more practice-based evidence, healthcare systems that vigorously and rigorously try new strategies, such as immediate mobilization of patients, and evaluate outcomes. Thank you for your time, your interest, and your commitment to keeping patients healthier and safer. Together, we can reduce the global burden of thrombosis.
Hello, everyone, and welcome to the World Thrombosis Day 2016 webinar, co-hosted today by the International Society on Thrombosis and Haemostasis, or ISTH, and by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. Today's webinar is titled Thrombosis, Know the Risk and Reduce the Burden. I'm Dr. Elaine Hylek, and I am delighted to be with you today. I serve as Professor of Medicine at the Boston University School of Medicine and Associate Director of the Education and Training Division of the Boston University Clinical Translational Science Institute in the United States. In addition, I'm a member of the World Thrombosis Day Steering Committee. World Thrombosis Day is a year-long campaign that culminates on the 13th of October and focuses attention on the often overlooked and misunderstood condition of thrombosis, also called venous thromboembolism or VTE. For today's webinar, I am pleased to serve as moderator. First off, I would like to thank Dr. Thomas Frieden, Director of the Centers for Disease Control and Prevention, for his opening remarks on the public health issue of VTE. Dr. Frieden, we are delighted that you could address this topic today, and we appreciate your comments on the importance of preventing healthcare-associated VTE. Before we get started, I would like to take a moment to review a few technical matters and let you know how you can participate in today's session. We very much would like today's webinar to be interactive, and as such, we encourage you to submit questions to our presenters using the Questions tab on the left side of your screen. Please feel free to submit your questions at any time. We will be monitoring questions and will try to respond more quickly if we see something that shouldn't wait until the Q&A period, for example, if we need to clarify something. I would also like to point out a great feature for those who wish to take notes during the presentation. When you click on the Notes tab on the right side of the screen, you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the presentation. If you're interested in a PDF copy of the PowerPoint or would like to download any file referenced during this talk, you can click on the Resources tab on the left side of the player. Simply click on any of the file names to initiate the download. A recording of this webinar will also be available. If you experience any technical problems during the course of this webinar, you can click on the Request Support button in the lower left of the player, and we have a technical expert available to assist you. So, why don't we get started? It's my absolute pleasure to introduce today's presenter, Dr. Gary Raskob. Dr. Raskob serves as Dean of the College of Public Health and Regents Professor of Epidemiology and Medicine at the University of Oklahoma Health Sciences Center in the United States. Dr. Raskob is Chairman of the World Thrombosis Day Steering Committee. Dr. Raskob's research and scholarly interests are in the prevention, diagnosis, and treatment of deep vein thrombosis and pulmonary embolism, the clinical development of antithrombotic drugs, clinical trials, prevention research, evidence-based medicine, and the translation of research evidence into practice and health policy. Dr. Raskob has participated extensively in clinical practice guideline development for several specialty organizations, including the American Society of Hematology, American Society of Chest Physicians, the American Thoracic Society, and the American Society of Clinical Oncology. He also serves as an advisor on thrombosis and hemostasis for the United States National Heart, Lung, and Blood Institute and the Centers for Disease Control and Prevention. Dr. Raskob joins us today to discuss the topic of thrombosis, know the risk, and reduce the burden. Dr. Raskob, thank you very much for being here with us today.
Thank you, Dr. Hylek, for that kind introduction. Thank you also for your leadership in research and education and care of patients with thrombosis, and it's a privilege to work with you. I also want to thank our colleagues at the CDC, and Director Frieden for their support and for co-hosting this webinar today. I'm showing my disclosures for the audience, and I want to say good morning, good afternoon, good evening to everyone, wherever you are throughout the world, as we begin the third annual World Thrombosis Day activities. In this webinar, I would like to cover just a few key objectives. I think we will review the burden of thrombosis as it pertains to the global burden of non-communicable disease. We'll describe the global burden of disease from both venous thromboembolism and then secondarily from a parallel condition on the arterial side, atrial fibrillation. We'll talk about the clinical features of venous thromboembolism, the risk factors and steps that people can take to reduce their own risk of venous thromboembolism. And we'll spend some time talking about the evidence for system-wide risk assessment of venous thromboembolism to reduce death and disability from venous thromboembolism. And this fits very well with the challenge that CDC has indicated in Dr. Friedman's comments to those hospitals that are working diligently on this effort. Now, as an epidemiologist involved in thrombosis for a long time, when I actually worked with colleagues to undertake a systematic review of the burden of thrombosis, it was striking that when we consider thrombosis as the underlying pathology to heart attack, to ischemic stroke, and to venous thromboembolism, we recognize, based on the global burden of disease study conducted by the WHO and the World Bank, that thrombosis is responsible for approximately 1 in 4 deaths globally. And the 3 main contributors, of course, are myocardial infarction, ischemic heart disease, thromboembolic stroke, and venous thromboembolism, which consists of deep vein thrombosis and pulmonary embolism. Now, as part of the activities of World Thrombosis Day 3 years ago, we conducted a survey globally to assess the general public awareness of thrombosis generally and venous thromboembolism in particular, as it pertains to the awareness of other conditions, health conditions. And what was striking is that while most people around the world are aware of conditions such as high blood pressure, heart attack, AIDS, stroke, breast cancer, prostate cancer, thrombosis per se was clearly associated with less awareness, and deep vein thrombosis, particularly in pulmonary embolism, had a much lower awareness, approximately half of the people, by contrast to the high 80s and 90% awareness seen for these other conditions. We believe that this is primarily due to the fact that while there have been very significant public awareness campaigns for heart disease and for stroke and for all these other conditions, breast cancer and AIDS, there has not been a coordinated campaign related to making people aware of the impact of venous thromboembolism. And that is what World Thrombosis Day is aiming to achieve. Now, when we discuss the impact of venous thromboembolism and of other thrombosis conditions, I will be using the term disability-adjusted life year, and this is common in assessing the impact of global health conditions. It's a standard measure of disease burden, and it indicates the years of healthy life lost due to premature death or non-fatal illness and disability. And so the way that a disability-adjusted life year is determined is the sum of the years of life lost or premature death due to a condition, plus the number of years an individual who survives a condition may live with a disability. And as we'll see a little bit later on, venous thromboembolism and thrombosis conditions are major contributors to disability-adjusted life years lost. So again, venous thromboembolism refers collectively to deep vein thrombosis and pulmonary embolism. Deep vein thrombosis usually originating in the deep veins of the legs, but can occur elsewhere, sometimes in the arms. Of patients who survive venous thromboembolism, about 60% will be presenting clinically as deep vein thrombosis, and about 40% is pulmonary embolism. The severity of a pulmonary embolus depends both on the size of the embolism, but also on the underlying cardiopulmonary status of the patient. And even smaller subsegmental pulmonary embolic events are important because they do have an important risk of recurrent events. This is a condition which, if not adequately managed, has a high rate of recurrent events. we can classify patients who present clinically with deep vein thrombosis or pulmonary embolism into two main categories, provoked and unprovoked. Provoked really refers to those patients who present clinically and have identifiable risk factors, known risk factors that are present when they present. And these main risk factors are hospitalization recently, surgery, cancer, medical illness, and as well as a number of other risk factors, inherited conditions, and so on. The important point is these risk factors may be transient or they may be continuing for a period of time or even indefinitely. If the risk factors that led to the development of venous thromboembolism are reversible or transient, such as a time in hospital or a surgical procedure, then these patients, after treatment with a standard duration of anticoagulation of approximately 3 months, have a relatively low risk of recurrence each year of about 2%. This contrasts with the unprovoked category of patients where their clinical presentation of venous thromboembolism occurs in the absence of an identifiable risk factor. The literature has also variably called this idiopathic, and different experts have treated minor risk factors as either being part of or not part of the definition of unprovoked. But generally, unprovoked do not have an identifiable risk factor. And the main point about these patients is that they are really at risk of recurrent venous thromboembolism over the course of an indefinite period or really their life if anticoagulation is withdrawn, at least as far as we know. If anticoagulation is withdrawn at 3, 6, 12, or 24 months, these patients then resume a high annual risk of recurrent thromboembolism. So these two categories classify patients who survive a venous thromboembolism generally. And the important message is that many of the patients with provoked venous thromboembolism, we have preventive measures that can be used. And with respect to unprovoked venous thromboembolism, of course, it's important to know the signs and symptoms and to seek appropriate attention and effective management. As Director Frieden indicated, this can reduce the complications and recurrence of the condition. So just to review the burden of disease from venous thromboembolism, it occurs in 1 to 3 episodes per 1,000 people in the general population, but this is heavily age-dependent, and as individuals age into the 70s and 80s and so on, the incidence increases very significantly to somewhere between 2 to 7 per 1,000 population above 70 years. Our colleagues at the CDC have documented more than 500,000 hospitalizations with venous thromboembolism in the United States each year during the period of 2007 to 2009. There are an estimated 900,000 cases per year in the U.S., with anywhere from 100,000 to perhaps 300,000 deaths from venous thromboembolism. In the European Union, studies have documented more than 500,000 deaths related to VTE each year. And the World Health Organization, through its patient safety program, has documented that venous thromboembolism is a leading cause of hospital-associated premature death and disability. So the premature death and disability contributing to the disability-adjusted life years lost worldwide. And this has occurred as the leading cause of an adverse event associated with hospital in low and middle-income countries, and the second leading cause of an adverse event associated with hospitalization in high-income countries. Now, our colleagues at the CDC have also documented that the incremental direct healthcare costs are about $7 to $10 billion annually in the U.S. This means that the cost attributed to the development of a first episode of venous thromboembolism among people and over and above all the other costs that they would incur to the healthcare system due to the various other conditions that they have, that the specific cost directly attributable to the first development of a venous thromboembolism is about $7 to $10 billion. And so this is a marker of the potential savings we could impact if we could markedly reduce the incidence of venous thromboembolism through effective preventive measures. And I would note that this cost of $7 to $10 billion is more than the entire budget of the Centers for Disease Control and Prevention in the United States. Now, other authors have documented a higher amount of direct healthcare costs associated with venous thromboembolism, perhaps 20 to 30 billion per year. And the difference in those studies has been that the higher costs are really also taking into consideration the fact that people who have venous thromboembolism then also incur added costs when they have recurrent thrombosis and when they have complications such as the post-thrombotic syndrome or pulmonary hypertension. And so beyond the first incidence, there are then added costs even greater, which are due to the morbidity and long-term disability caused by venous thromboembolism. And there has been recent evidence published just very recently in the last 3 months or so that in patients who present with unprovoked venous thromboembolism, they have an increased risk, a hazard ratio of 1.5, of having a work-related disability throughout their life. So who is at risk for developing venous thromboembolism? This slide shows the classic Virchows Triad, the pathologist on whose birthday we have designated World Thrombosis Day, October 13th. And many of you will know that Virchow described the pathologic features that predispose to the development of venous thromboembolism. These are a hypercoagulable state or activated blood coagulation, slow flow of blood in the veins or venous stasis, and damage to the lining of the veins or arteries, endothelial injury. And specifically, Virchow was focusing on venous conditions. And on this slide, what we have done is we've showed for each of these three pathologic features the clinical risk factors that operate through those mechanisms and predispose patients to the development of thrombosis. And you see that surgery, trauma, catheterization can lead to endothelial damage, the damage to the lining of the veins. Immobility due to hospitalization or recovery postoperatively or paralysis, heart failure, and venous obstruction may lead to venous stasis and pooling of the blood in the veins. And then coagulation is activated acutely in the postoperative phase, and other conditions such as cancer, thrombophilia, medications, pregnancy, inflammatory conditions activate coagulation systemically. And when these features come together, usually two of these features together or three will then promote the development of venous thrombosis and venous thromboembolism. Now, again, back to our global survey, it was striking to us that across 9 countries around the world, that there was a lack of awareness of the major risk factors for venous thromboembolism amongst the general public. Only 16% knew that cancer could predispose to blood clots. Only 25% of individuals knew that a hospital stay was a risk factor, and only 36% that surgery was a risk factor. So you can see that there was really a lack of awareness, and less than half of individuals were aware that this condition is potentially preventable. We feel that this is a very important then target for a global public awareness campaign because, as I'm going to note in a minute, there are things that individual patients can do to enhance their ability to be active in their own care and reduce their risk of thrombosis. Hospital-associated venous thromboembolism, which is the focus for this year's World Thrombosis Day, accounts for about 60% of all the incident venous thromboembolic cases. So of all the new cases every year, about 60% of those are attributable to the patient having a recent hospitalization, or at least their patient has a history of a recent hospitalization. This means that hospital provides a key access point for us to have patients engaged and for us to implement prevention. Now, this doesn't mean they develop thrombosis during the hospitalization only. The risk period often extends beyond the hospital period, and that's being seen increasingly as the lengths of stay for a variety of hospital conditions are shortened in recent years. We see this across the world. The good news is that we do have effective preventive measures, mostly either anticoagulant drugs or mechanical methods. And therefore, because there are effective ways to markedly reduce an individual's risk of developing venous thromboembolism when they are hospitalized and in the post-hospital period, a risk assessment is indicated for all patients admitted to hospital. Now, let's just look at some of the data for health systems that have mandated the use of a VTE risk assessment in hospitals. And in 2010, this was implemented by the National Health Service in England, where a national target was set that 90% or more of hospitalized patients should be assessed for venous thromboembolism when they are admitted to hospital using a standardized tool. And the health system then indicated that if a hospital did not achieve this target, a financial penalty would be applied. And what was demonstrated when the data became available over the subsequent couple of years, that following out to 90 days, the implementation of this mandatory risk assessment by the hospitals in the system reduced the mortality from venous thromboembolism by 15%, a relative risk reduction of 15%, for those that achieved the target of 90%, compared to those hospitals that did not achieve this target. So it was a concurrent comparison over the time frame for those that achieved the target. This was observed both in medical and in surgical patients, and subsequent estimates suggested that about 900 deaths from venous thromboembolism were avoided in England just in those 2 years. The equivalent number for the United States proportionately would be about 4,500 deaths avoided just in that 2-year period. Now, we have added evidence from this from colleagues in the United States in postoperative patients. Cassidy and colleagues implemented a combined strategy to decrease postoperative venous thromboembolism in their surgical patients who were hospitalized. This consisted of a standardized order program through the electronic medical record that specified early mobilization, mandatory risk assessment using the Caprini score, which I'll say a bit more about in a moment, prophylaxis that was then linked to the patient's risk assessment. It incorporated the appropriate use of both mechanical or pharmacologic methods, and it generated electronic reminders automatically to the healthcare team, the physicians and nurses caring for the patient. And they documented in the time frame 2 years after implementing this system that they reduced symptomatic deep vein thrombosis in their during the 30 days after hospitalization by from 1.9% to 0.3%, a risk reduction of 84%, and a 55% relative risk reduction in symptomatic pulmonary embolism. So we have added evidence also that when a coordinated approach to do risk assessment and link actions to that risk assessment in a mandatory way, we do reduce the risk of venous thromboembolism. This evidence, plus additional extensive literature, has led our ISTH steering committee to make a call to action this year that all hospitals should implement routine risk assessment for venous thromboembolism in their patients when they are admitted. There are validated risk assessment models throughout the literature. The Caprini score is validated for non-orthopedic surgical patients. The improved VTE risk assessment model is validated extensively in patients hospitalized for medical illness such as heart failure, chronic obstructive pulmonary disease, pneumonia, infection, rheumatic disease, and so on. And the tool used by the National Health Service in England, as we've shown, has outcome data to support its efficacy. Emerging data is also coming forward that the simple blood test, the Ddimer, which is the breakdown product of fibrin, is likely to be very useful in hospitalized medical patients for identifying a group of individuals at increased risk of developing venous thromboembolism. Patients undergoing hip or knee replacement, surgery for fractured hip, those patients at the present time should receive prophylaxis unless it's contraindicated, and therefore a specific patient risk assessment in that group is not needed because the surgical procedures themselves outweigh or swamp the risk contributed by the variety of other factors that are used in these risk assessment models. It's important to emphasize, as we have, that what we're calling for here is for simply all hospitals, hospital systems to do a risk assessment. The actual decision about the prophylaxis and the choice of the measure is still made by the patient's physician and surgeon caring for the patient. System-wide coordination of this effort, however, as we've seen, can reduce the events from venous thromboembolism, and continuous quality improvement measures can be applied to refine and tweak any type of system that is implemented. And so we have called for this routine risk assessment in all hospitalized patients, and we ask that clinical leaders, hospital systems, and payers work together to achieve this goal. For the general public, there are things that they can do to reduce your risk of venous thromboembolism. Know the risk factors, hospitalization, surgery, cancer are the big ones. Know that venous thromboembolism is preventable and be proactive in your own care. If you are hospitalized or having surgery, simply ask for a risk assessment. What is my risk of developing a blood clot? Please assess my risk, and what can be done to lower my risk should I receive some type of preventive measure. And by taking an active role in your own care, I think individual patients at the time of hospitalization can help to ensure that they receive the appropriate strategies to reduce their risk of venous thromboembolism. Now, the next couple slides, I'd like to talk a little bit about where we are going with research in the future to try and really impact this. And I'd like to make the point here that I think that overall, if we look now what's happening and you see the evidence from the study by Cassidy and what can be done in the post-operative situation, particularly with elective surgical patients, we really have the potential there to affect fatal pulmonary embolism very significantly. But most of the deaths from pulmonary embolism we know occur in medical patients admitted to hospital with medical conditions. And we also know that many, if not most, of these deaths from pulmonary embolism are not recognized before the patient dies by clinical assessment because they're often confused on the background of patients' other cardiorespiratory illness. And so patients have heart failure and chronic pulmonary disease and other things that give them cardiorespiratory symptoms that are also symptoms of pulmonary embolism. And in these patients with impaired cardiopulmonary function, even a small embolus may be lethal to these patients because they cannot tolerate it. And so we know from many, many autopsy studies that the clinical surveillance, looking for patients who develop symptoms and signs and then investigating them, won't work to reduce death from pulmonary embolism. And there are many fatal pulmonary embolic events among these medical patients. There have been clinical trials to enhance prevention in these patients because we know also from studies that the risk of developing venous thromboembolism extends far beyond the duration of the hospital stay, which now on average is only 4 to 5 days in the United States and is also occurring elsewhere across the globe, these short hospital stays. But we know that the patient remains at risk for 30 to 60 to even 90 days post-hospital. And so there have been clinical trials of extended duration anticoagulant prophylaxis, giving prophylaxis beyond hospital discharge in these patients. And there have been 4 such studies published and are summarized in this slide. The first 3, the top 3, did not lead to a major adoption of post-hospital prophylaxis among medical patients because it was a finely tuned trade-off of the risk of important bleeding complications compared to the thromboembolic events that occurred. So we have to be sure that with the prevention approach, we have a safe approach and that we don't do more harm than good. And these studies, as you can see there, led to modest absolute reductions in major venous thromboembolism, that is, either symptomatic events or proximal vein thrombosis detected by routine screening, but major bleeding seemed to a certain extent, offset this benefit. And in addition, these studies included a broad range of patients with really uncertainty at the end as to how to select an individual patient to optimize the risk-benefit of prophylaxis. More recently, just this year in May, we had the APEX study published, which was a trial to look at the benefit of a new oral factor X inhibitor drug, Virchows, continued post-hospital compared to the standard care prophylaxis with enoxaparin given just for the hospital stay. And this approach resulted in an absolute reduction of major venous thromboembolism of 1.7%, and it did not result in an increase, at least a significant increase, in major bleeding. As you can see, it was only 0.1%. So for the first time, we see some indication that we may be able to, through selection of patients, and this study used the plasma Ddimer measurement as a way of helping to select patients for the trial, that we see that we may be moving to where we can refine the care of the medical patients and identify a group that may have a benefit of post-discharge prophylaxis. I would just point out, if you look at the APEX article also, even though there is concern about bleeding, when you look at the fatal events in this study, there were 20 times more deaths from venous thromboembolism than there was contributed to death from bleeding. In the 7,000 patient study, there was only 2 deaths from bleeding. There were 20 times more deaths from venous thromboembolism. So we're beginning to learn through research how we might be able to find a little bit more optimization. And this really leads to patient selection. So the ongoing study, the Mariner trial, will add and build upon, I think, what the APEX is showing. The design of that study is shown here. This is taking patients admitted to hospital with medical illness, using the improved risk assessment score combined with the Ddimer to select patients for inclusion in the study. And so we'll have a very specific set of rules that we can give to hospitals and physicians about how to select patients for this intervention. And then at the time of discharge from hospital, randomizing patients to receive ongoing prophylaxis with the factor Xa inhibitor rivaroxaban or placebo. The rivaroxaban dose is adjusted according to the renal function. That's another important step that we think will enhance the safety. And this will be at least 8,000 patients to test whether we can get a 40% relative risk reduction in symptomatic events only. We're not counting asymptomatic thrombi in this trial. And I think this study, together with the results from APEX, should help to clarify and perhaps even strengthen our ability to prevent venous thromboembolism among high-risk medical patients who are hospitalized. Now, it's important just quickly to look at treatment of venous thromboembolism and to remember that for many years we had relatively few approaches for long-term treatment. But this slide shows that the treatment of venous thromboembolism is generally categorized into 3 phases: the initial or acute treatment for 5 to 10 days, treatment then for 3 to 6 months long-term. All patients should receive at least 3 months. and then the extended treatment beyond 6 months, indefinitely or lifelong in some patients. And what's changed our whole ability here has been the development of new oral anticoagulant drugs, which are easy to administer without the need for routine laboratory monitoring of the anticoagulant effect, which have much fewer interactions with food and other medications than the standard vitamin K antagonists that were the mainstay of treatment for many, many years. And what this means is that we now have a much easier way to give patients long-term anticoagulant prophylaxis. And this is important because going back to our presentation of the other group, the unprovoked thromboembolism, the prevention of recurrent venous thromboembolic events is another important way that we can attack the burden of venous thromboembolism and reduce that burden very significantly. Our assessment in hospitalization and prevention, primary prevention, is really targeted at the provoked venous thromboembolism. We can really begin to help reduce the burden of venous thromboembolism in the unprovoked population by certainly doing our best to prevent recurrent thromboembolic events, and that will also help to reduce the disability caused by this condition. Now, there have been several studies looking at the extended or indefinite treatment of patients with unprovoked venous thromboembolism using either the new direct oral anticoagulants, labeled here as the DOAC, or with aspirin. And you can see here that this slide has shown the absolute risk reduction in recurrent events for either of those regimens compared to placebo treatment. And you see that there is substantive risk reductions, both absolute as well as relative. It appears that the effects of the oral anticoagulants are larger than that with aspirin, although these are not based on direct comparison. The number needed to treat to prevent one recurrent VTE event is shown, and ranging from 14 to 20 for the direct oral anticoagulants, 22 to 59 for aspirin. These are important numbers of big impact. The absolute risk for major bleeding is also shown, and I think it's important to note here that although this may go against physicians' intuitive thinking, there's no evidence from clinical trials that in the context of treating patients with unprovoked venous thromboembolism long-term, indefinitely, we don't have evidence that aspirin is safer than the direct oral anticoagulants. The risks of major bleeding are shown there in terms of major bleeding. Now, it is true that it's likely the risk of clinically relevant non-major bleeding will be higher with the direct oral anticoagulants than for aspirin. We hope that ongoing studies, which may be refining the regimens, perhaps looking at lower doses of direct oral anticoagulants, may help to also bring down our risk of clinically relevant non-major bleeding. But we have interventions now, the new oral anticoagulants, easy to administer and to take for patients once or twice a day without monitoring, or aspirin that can help reduce the burden from recurrent thromboembolism among patients with unprovoked VTE. Let's turn then to a parallel condition, atrial fibrillation, because you recall that thrombosis is the underlying cause of death for 1 in 4 deaths globally. If we are to achieve the World Health Assembly's goal of reducing death from non-communicable diseases by 25% by the year 2025, we have to target thrombosis, and we have to include arterial thrombosis in that targeting as well as the venous if we're going to get at those 1 in 4 deaths. Atrial fibrillation, of course, is a common type of arrhythmia, which is affecting many people, and I'll show you the burden of disease. And this, in many ways, has parallels to venous thromboembolism because it's a condition where we can intervene to prevent the serious thromboembolic complication, which is stroke. Again, with atrial fibrillation, thrombi form in the atria and then are ejected systemically, usually to the brain or elsewhere in the body, and cause thromboembolic complications and a major risk factor for stroke. Now, when we look at the disease burden of atrial fibrillation across the world, this is profound. The recent Global Burden of Disease study in 2010 showed that there were 33 million people with this across the world, because for many patients, this is a permanent condition, long-standing or permanent condition. 3 to 5 million individuals in the United States with this condition, but these numbers are estimated to grow very significantly due to the aging of the population, and we're looking at globally 4.7 million new cases each year based on the 2010 population, meaning that these numbers will grow quite significantly. We'll expect probably up to 10 million people in the United States by 2025, probably maybe over 18 million in the European Union. The incidence of atrial fibrillation, of course, shows a marked age dependence and regional variation across the world. It's highest in North America, lowest in the Asia-Pacific region, and it's higher among developed countries. You see here in North America, among men, the incidence is age-dependent. Annual incidence is shown 2.4 cases per 1,000 in age 50 to 54. But as you see, when you get up to 70 to 74 or 80-plus years, a really profound incidence of this condition, much lower across the Asia-Pacific region, although, again, with high life expectancies and large populations there will still be a substantive burden of this condition. Now, why this is the case is generally because we have done a better job of dealing with the risk factors for this. We have improved the management of myocardial infarction and acute coronary syndrome such that we've reduced the mortality from that many patients are living longer with risk factors such as hypertension, ischemic heart disease, diabetes, heart failure, and so on. And so they are at risk for developing atrial fibrillation. This, again, the profound impact of this cannot be overemphasized. I think 10% of men and 5% of women in North America and Europe over 80 develop this. For a developed country, lifetime risk is 1 in 5 for a man. And the disability-adjusted life years due to this condition, atrial fibrillation causing stroke, have doubled since 1990, including the mortality. And a striking feature from the OXVASC study was that 44% of the disabling or fatal strokes in this cohort study were related to atrial fibrillation. And in many, if not most of those conditions, the first time that the patient was identified to have this atrial fibrillation was at the time they presented with a stroke. And so what we want to do is, again, increase awareness of this because we have an opportunity to prevent stroke and reduce the burden. In summary, we can reduce the burden of thrombosis very significantly. Venous thromboembolism is a winnable battle, as CDC Director Frieden likes to frame public health conditions. If we improve public awareness, if people are knowledgeable of the risk factors and ask for risk assessment, and if clinical leaders, hospitals, and payers work together, we can get risk assessment in all hospitalized patients, and I think that this will result in improved application of appropriate prophylaxis. Atrial fibrillation is an important opportunity to intervene to prevent stroke, and so by identifying patients with atrial fibrillation and acting, we can have a big impact here. And so the parallel method to asking for a risk assessment when you're hospitalized is anytime you see a health professional, ask to have your pulse checked. And there's evidence from a Cochrane review that the process of simply checking a person's pulse and then linking that, if an abnormality is felt, to appropriate ECG testing, either a single measurement or subsequent Holter monitoring or even more prolonged monitoring, that this will identify patients with atrial fibrillation and will allow for the intervention to reduce their risk of stroke. So, in conclusion, if you're hospitalized or having surgery, ask for a VTE risk assessment. When you see a health professional, ask for your pulse to be checked every time. And we can target these two areas of preventable thrombosis and work to reduce the burden. I want to thank again our colleagues at the CDC for co-hosting this. Thank you, Dr. Hylek. And it's a pleasure, and I'm happy to turn it back to you.
Okay, great. So, Dr. Raskob, we have a ton of questions for you, so I'm going to ask you to really please be succinct in your answers so that we can fit in as many as possible. The first one has to do with, are there any validated risk assessment tools for pregnancy?
Very good question. Lots of research in that area, but at the moment, no. But there is quite a literature on that of evolving strategies. Okay.
Another question has to do with this economic concept of the DALY, the Disability Adjusted Life Year. And can you just explain what that is and why we use it?
Yes. Again, it is a measure of the disease burden that allows us to assess the impact of a disease from a global health perspective. And it refers to both the combination of the impact of a condition in resulting in a premature death of someone, prior to achieving their life expectancy, or the number of years that they have lost some health due to living with a chronic condition and the disability caused by that condition, such as the post-thrombotic syndrome or pulmonary hypertension. And together, those two things, years of life lost and years lived with the disability, combine to give you the DALY.
Okay, that's great. Another question has to deal with the VTE Risk Assessment tools and the risk assessment, and if there is any form that one could simply get online and download and use and pass out to the individual patients or hospital staff.
So, yes, very good question. Again, because of time today, I didn't go to the details of those tools, but I think in each of those conditions, I think that certainly the National Health Service in England will, has their tool available, and by going to those publications or searching their website, I'm sure you can access that. The Caprini score is also available in the publication cited in the slides, as well as the improved risk assessment. And I think that some of these are actually being adapted into apps for your phone and so forth. So there is effort in that area.
Okay, and we have a question about the newer oral anticoagulants, stating that they're expensive, and, not everyone's insurance is going to be supporting a use of those long term. And besides warfarin, do you have any suggestions for that problem?
Yes, thank you. So I think that, that's going to depend on the clinical context of whether we're using that for prevention or treatment of established thrombosis. I think there is emerging data that treatment of established thrombosis, the agents are cost effective. This will, of course, depend on the resources of individual health systems and insurance models. In the context of primary prevention beyond elective orthopedics, these agents are still, as I said, are subject of research in medical patients. But I think as time goes on, the evidence builds, you will likely see further evidence of cost effectiveness, that, in other words, that the cost of the intervention is reasonable relative to the mortality and morbidity it prevents compared to other things we do in healthcare. But this is going to be so highly variable according to a particular country's health system or private insurance system.
Okay. And what are your thoughts about aspirin as prophylaxis in hip and knee surgery? What do you tell your patients?
Of course, that has been a long-standing controversy, mainly in the United States. I think beyond the United States, most orthopedists are comfortable with the fact that anticoagulant prophylaxis is indicated. I personally think that the evidence shows that anticoagulant prophylaxis is likely to be more effective than aspirin during the hospital phase. there is good evidence that in patients who are given anticoagulants such as low molecular weight heparin or the new oral anticoagulants during their hospitalization after a hip replacement, if they go on to aspirin in the outpatient phase, that is a good approach and reduces symptomatic events, or is at least non-inferior there. And so I think that we'll see emerging data on that as well. There's a big study that has finished called the EPCAT study in Canada, which compared aspirin to the oral factor Xa inhibitor rivaroxaban post-hospital discharge in hip replacement, and that will be awaited with interest. But I think for your hospital phase, I personally think the evidence favors anticoagulation over aspirin. Once you go home, aspirin may be an option.
Okay, and I think we have time for maybe just two additional questions. Are you using the Ddimer in any way to predict recurrence in your practice?
That's a great question. I think there's evidence that Ddimer can be used to do that. I personally think that it doesn't help all that much because the key issue is amongst patients with unprovoked venous thromboembolism, would a negative result give you a low enough risk that you may not want to continue treatment? And I think the evidence to date is not. The annual risks came down to only about 4% or so. And as we get improved safety of our long-term therapies, I think that's not low enough to say definitively you can withhold it. So my concern about the Ddimer is its ability to tell us which patient you would not want to treat. It's easy to pick out, the unprovoked patients and the others with other risk factors that should continue on. But in my view, the Ddimer has not been that effective in telling us who to withhold treatment from, and for that reason, I wouldn't use it.
And then if you could be brief with the last two that are very similar, stratification tools for children, hospitalized, and OB patients. As
you mentioned, children, it allowed me to move to the very last slide and to make all our viewers aware that there will be a particular webinar on children. And since I don't deal with children, I really can't answer that question. Can you repeat the second one?
OB patients.
And specifically?
Is there a specific risk assessment tool?
Yeah, very good. There are some publications trying to adapt and apply the Caprini score to OB patients, and this is ongoing as well. So it's not completely finalized. I think the key thing, I think most people would accept that a history of previous venous thromboembolism is a key marker, or family history is other issues. And research is still ongoing about the risk assessment tools in terms of refining it further.
Okay. So I'm going to apologize for any of our listeners and viewers who were, we didn't get to their question, but we really were deluged for the last 15 minutes with questions, and I apologize. But I would like to personally thank Dr. Raskob for this really important presentation, and hope everyone has also found it useful. Following this presentation, you will receive the presentation from today's webinar, and we encourage you to please visit www.worldthrombosis.org to learn more about the World Thrombosis Day Global Awareness Campaign, and also at the link shown for the CDC's webinar archive page. And please join next month's offering of the CDC's Public Health Webinar Series on blood disorders with Dr. Neil Goldenberg. And again, thank you all very much for participating today, and we greatly appreciate your support of World Thrombosis Day. Thank you.